and we'll go on towards the aneurysms, and aneurysms will start with the flow diverters, all right. Flow diverters are great technology, all right, and all of us are using them and we use them, but again, I think there are a lot of technical improvement which we can bring in. So rather than showing those pre and post cases, we are trying to go methodically how we improve our technical performance in flow diverters, all right. And of course, last 2 days, those 28 students really had a lot of experience, but now we'll have the first session on setting it right. To me, deployment is the key. And can I invite Dr. Tofel, Sukalyan, and Manish as chairpersons? And the first talk will be one of the best teachers we have in India, Dr. Mathew Cherian. And he'll be talking about the key hand movements in deployment, how he ensures and how he teaches his students to deploy a flow diverter to get it right.
So, Vipul, when you asked me the key hand movements, I was wondering, should I take a picture of the hand and or should I sort of animate this whole thing? And I finally decided to animate it. So I hope that you'll get the basic fundamental of the key hand movements. So I know there are a lot of people who do very fancy movements, look very stylish, and some people may not look so stylish, but the bottom line is that you do your job right. And even yesterday when I was doing in slice, I said it's more important you deploy it right. It may not look very stylish, but as long as you get your job done, it's fine. So to understand the key hand movements, the first thing you got to understand is what exactly is or how exactly is a flow diverter loaded. So this is the unconstrained flow diverter, you can see over here. To keep it constrained, you'll have a little pedal in most of the devices. This pedal is what that keeps it in place, and sometimes when you start deploying it, the pedal doesn't release, and because it doesn't release, it may take a cigar shape. So one of the things that I often do really is to actually open the flow diverter in an ICA, in the MCA, and then sort of recapture it back. And when you recapture it, this pedals actually move forward, ensuring that the next time you open, it will open. And that's very important when you want a precise position, especially in a vessel with a bend like the siphon. Also realize one thing, that right over here, there will be two markers. And this is like a pad that holds the stent retriever in place, and you have to keep these markers. Once your microcatheter even touches this marker, after that manipulation itself may release the FD, and even you will not be able to retract it. Having said that, there's a limit also to recapture a flow diverter. Up to 3 is fine, but 4th actually they start slipping and you may actually lose it. So it doesn't mean you can do it for eternity. Now, this pink is the blood vessel. The green is your DAC. I took green because one of the common DAC catheters we use is the Cat5, which is blue in color. Inside that is your microcatheter. The microcatheter, very commonly for a large vessel, is a 2-7. The little marker over here is the distal tip marker, and you got to keep this always in focus and in your mind. When you pass the stent retriever across, and as the wire comes out of this point, you will see 2 dots. Keep these 2 dots in view. This is your lifeline. Except for the phenox, in every other stent retriever, once you cross this point, then it becomes a point of no return. So try to do all your manipulations somewhere about a little ahead, a few millimeters ahead. So what I meant is, if you want to try things, please don't try it after you come to this point. The first step, therefore, is pulling back on the micro. Can you see that? Your wire is kept fixed. You draw back the microcatheter, and as you draw back, the flow diverter is expected to open this way. In case it doesn't open, take the microcatheter forward one more time, recapture it, and those little petals that hold it will allow the release to take place. Now that you've got this in place, what is the next step? Remember, at this point, if you push the whole device forward, I'm not talking about pushing just the mandrel forward, you push the whole device forward, it will tend to come and now peg itself on the walls of the blood vessel, right? So you got that, you push this forward, it actually holds and grabs the sides of the blood vessel, and that is the next step that you would do. At this point, if you're not happy with the position, don't be afraid, recapture it back, push your micro a little forward or backward and restart the step. After this, after that gentle push, start pushing on the mantle as the arrow shows. What happens is, it starts opening up in a nice little funnel like this. This is fine on a straight vessel, and we'll keep it for that for the time being. Once you do that, again do this little push. Every time you push, the braids are now coming up to that close to the 120 angle that you wanted to happen, opposes the wall, and this is a very, very important step. Just because you feel your flow diverter is getting a little short, do not try to keep it lengthened, it's not going to work. It will be a disaster. If that's the problem, better capture back, start afresh with a new flow diverter. And then the next step, you gently pull it back, releasing the tension and bringing the microcatheter to the center again. And then push a little bit and pull, and this is basically the technique that you do. By now the dots, as you see, have come over here. When you come to this point, the best thing is keep it at a neutral position and again retract the microcatheter. Have you got it? So it's a pull and a push, a pull and a push. It's basically you retract, push the whole device forward, come back to neutral position, now push on the mandrel alone, let the flow diverter come out a bit. If you want, I can go through it a little faster one more time to tell you each of these steps. So this is the first step. You retracted your micro. You're pushing on the whole system to get a little bit. At this time, you can even push out a little bit if you feel you've not got enough length. Keep pushing on the central mandrel. You'll find, as you see, the dots are coming closer to the point of no return. At this time, you can still play a little bit, push it forward, pull it a bit backward, and at this point, you can actually pull back on the micro and you released it. One of the problems that you can have is a fish mouthing. So what typically happens is this, you do this and you get a flow diverter should typically look like this. Sometimes it looks like this. One of the ways actually is to pull and push on the central mandrel, and at times it might open, but more often than that this doesn't happen, so it might actually twist it. It's better therefore to retrieve the stent retriever into the sheath or into the micro, and then once again try a deployment with a little bit of push. Okay? The next thing is your tension right. Now when you start deploying, like I told first, it looks like this funnel. You push a little more out, it looks like this. Now this happens not because you pushed, but because you unsheathed. Now like I said in the beginning, you deploy a bit, it touches the wall, then don't keep unsheathing but push out. This is basically called a champagne glass look. Okay, champagne is good for celebration, but not for your FD, right? So now you can do a thing to correct it, just push it forward. Push the whole unit forward. That means just push the micro forward without holding onto the wire. When we were training yesterday, I found many people were holding the wire and pushing forward. That is recapturing. Hold the micro, push it forward, and now you'll get a shape which is ideal. But if you push it a little more forward, it goes under tension. This shape is typically described as a martini glass. Even if you don't drink, maybe you get used to these glasses. Fine, so this is again not right. Pull it back a little bit and you get a look which is typically called the wine glass look. Go slow, there is no hurry. Even when you're working with people, some people be in a big hurry. I don't know why. You can take all your time deploying the flow diverter. Nothing is going to happen, right? So you got that again. So when you start this, you may start where it looks like a flute-like glass and you have to push it forward, get that corrected. If it is too high, pull it backwards, make it look like a wine glass, and which is typically understood when the micro is bang on the center. Okay, but sometimes you're confused. This looks bad. Now, is it a bend or is it a twisted FD or AC tip something that just happened because it's a bend. So in this case, if you have a biplane, look at the second plane. If it's seen in both planes exactly alike and tight, you probably twisted it and can be difficult to untwist. There is nothing wrong in trying to recapture and trying to unsheath it one more time, but if it happens 2-3 times, you probably you're much better off taking off the device. But on the other hand, if in one view is this way, on the other view it's open. Now if it's not a biplane, just rotate it around your C-arm and you can see this. You know it's basically a problem of not opening. The last and the most important test, the push and the pull. So when you do a flow diverter across the bend, it will invariably look like this. And this is the place that you have to ensure you get your position right. All the techniques after this, once you deploy, are much more challenging than this, right? So the first thing you do is push it forward. It may open a little bit. Interestingly, after that, when you pull it backward, it might open. You may have to do it several times. It may not happen the first time. It's a push and a pull and a push and a pull, and you slowly find it opening up. Sometimes you have to recapture a bit. Sometimes it will give a little length. You never know what really will do the job, but most of the time it will open if you're patient. The next, now you deploy the stent and massage. Who doesn't like one of these, right? Even an FT works exactly that way, right? Okay, how do you give a massage to an FT? Once you deploy the stent across, the flow diverter across, take your microcatheter across it. Keeping the wire inside. Please don't keep the wire outside. What will happen is it will perforate a vessel, push, and now what happens is the micro moves forward on the bend. See that? Invariably this will happen. As you push, and when this happens, it stretches this forward. And this is called a massage, right? And you can do that a couple of times up and down. Keep your micro quite distally. It's very, very safe. The next one is the bumping, right? Bumping is an extremely useful technique. At the same time, please don't go on aggressive bumping. Nobody likes it. You won't like it and your FT won't like it. How do you do a bumping? This is typically done when the proximal end is not opposed. Like in this picture. What would you like to do? Now you have it here. Take your DAC across. It will generally touch the edge. And as you gently push it forward, it will open up. Now one of the things I've noticed if it's just the proximal end, everything else is fine, pull out the micro and do this maneuver, it will work even better because when the micro is inside with the wire, it's sent to centralize the DAC and it may not go. But this, please be gentle, don't go pretty violent on this. Sometimes it goes outside the FD, you'll have a fish mouthing. You push too hard, it kind of gets crumpled or crimpled and you can have a problem with that. So these are just to show you a large aneurysm and how one can treat successfully, but this is not showing any technique, just to show. So it's some of these maneuvers. So this you've got the Cat5, the Synchro. I don't know if you can see it on your monitors. I hope you can. And so this is what is done. You've got this across here. But when you do a Dynacity, always do a Dynacity. I know in India some people say they do not have, but whenever you have it as a protocol, even if it looks well opposed, do the Dynacity because you will think it's opposed. It wasn't, because here everything looks fine, but actually you see the distal end is not opposed. So what do you do? This is where you do the massage. And how do you do it? You can just see what's happening. You're taking the micro across like I told you, and then as you go across, you start manipulating on the micro, and as you pull and push, and as you pull and push, you will actually get the FT to open, okay? Okay, the wire is little out. Normally the wire should be in. It's much safer. And as you do this, you will actually get this to open up. So that is called the massaging technique as you do with the wire. And okay, here is another aneurysm. we got an working angle, the angle looks tight. We got an infinity and the triaxial combination, the Cat5 and all that stuff. And you can see the FT over here. And as you deploy, invariably you find this segment will be narrow. Just see what we're doing. We are actually pulling and pushing and pulling and pushing. You'll see that maneuver. Can we call it? The push, the pull, the push, the pull. And this is as you do, you'll get the FT open. Like I said, take your time. Can you see the pull, the push as it opens up? And then you'll finally get this open and you'll get a good position. Okay? But at the end of the day, you see there's still poor a position over here on the Dynacity. So what do you do? This is where you do the bumping. So this is the Cat5 over here. We are taking the Cat5 up. Here we are doing a bump exactly at the spot that is the upper end. Massaging usually will not help because massage just pushes the upper end here, the convexity here. So as we take it up, it actually pushes against it and it will give you the expansion you want. I don't know if you saw it, but this is exactly what you want. You gently push it and you got that opening taking place, right? Okay. Now if you want to see this open well, do it on a blank roadmap. I'll show you over here what we did. This is to show you doing it. I'm moving it fast. We never move it this fast. Okay, just see this. On the roadmap here, you see that black line up here, which means the FT has shifted up and you got the position that you want. So you can actually do a bump and a massage together and finally you can get this even with your DAC or the Cat5 at times. The final injection, which is good. So again, another case showing you the bumping. Here you have the flow diverter. You can see the lower end is not looking too great. You take the micro, so you can see this is right here, and you gently move this. Of course, one of the things that happens I want to show is when you do the bump sometimes, if it's not moving, look at the neck. It just means you're probably a catheter has just slipped out, Okay. So we just do this maneuver. Bump, bump. Can you see that? Gently touching it to make the flow diverter oppose a little better. And that's how we do the bumping, and you can get that done. Okay, that's an improved position and showing a good. So this is another case. Out here looks straightforward. We do
Mathew,
time is up, is it?
I think so, if you don't mind.
Yeah.
Can you show some other quickly, one or two important
Just
techniques?
the last one if you want, I can. The problem is if you want to show a technique, you can just have a look, the push and pull again. I'm just running it really fast, but you can get the idea of how this is done. It's a push and a pull and a push and a pull, and usually you do multiple maneuvers. By itself, it's not enough. Okay.
Is that the advantage or was that?
Okay, I think I'll just to show you it's all fine, I think. And the last one, of course, is when you have a tough case, you may finally have to do a balloon angioplasty. And if you do it well, often you won't need it. So just to show you this last one, I think this is the last. So just to show you this bit, this is it. We complete it, and in the neck, in the angle out there, it's still not open, and it's not on a post, and if it still doesn't work, take this balloon and it works. So remember, when you use a balloon, I use a compliant balloon, and it's always the balloon is inside the FT, not sticking out. Okay, I think that's it.
What stent was that, Mathew?
All these are FDs, sorry, not the
I
same.
think,
So final FD needs to be pull, push, massage. It's like a relationship, you never know what works.
I think this was absolutely lovely. This is
Thank
what
you, that was
exactly.
amazing, thank you very much.
This was, I think every student who starting doing FD should watch this talk. And what I loved about the talk is, we all talk about, we jump to balloon and stents in the end. The key, as he mentioned, is during the delivery, all the maneuvers you can do. We'll get these, we are planning to build a site, all these talks will be there, and I would tell everybody to look at through again. He covered all the maneuvers. So best part to me is that during delivery itself, use this maneuver to open up. Don't say, okay, it's not opening up, let's deploy, we'll do balloon. You see, balloon he showed in the end. He showed all the maneuvers which can be done during deployment. And he showed all the maneuvers, simple maneuvers using micro catheter and guiding catheter which can be done after deployment. And only in the last he showed a balloon angioplasty. I think that's a key in flow diverter safety. Don't rely on balloon straight away. Use all these maneuvers, keep thinking. And another key point which he mentioned was, I'm sorry I'm taking all this time, but I think this talk was so important to me, that think through. There's no hurry. Retrieve, redeploy. We need not deploy like an expert in 5 to 10 minutes. Take half an hour, 45 minutes, redeploy, think it over, look at the other view. Is it twist? Is it narrowed? Recapture, redeploy, use a different maneuver. And he showed you all the different maneuvers, which I think one should go through this talk again and again. And he showed the videos of it all. So I think this was absolutely what we wanted. And he has done even better than that. So, I mean, okay, so this is, I think, the talk was great. One should watch again. Everybody, every delivery is just not delivering it. Just, okay, it will expand. Some industry will say, oh, our FD will just expand, just release it. No, no, no. You have to keep doing this at each step. Keep thinking through which step is going to work and use it accordingly. Yeah, Tufail, you wanted to ask a question, and then go ahead.
I think, Mathew, I was just going to ask you, the last case that you tried to angioplasty, was that a pipeline or a evolve? And the one before, was that a pipeline or the evolve?
So most of what I showed is the surpass.
Okay.
And so what I showed, the last set of workers, most of them were. So
But
in
Tufail-
general, maybe in 25 or 30 FDs, I may just angioplasty one. The vast majority we manage just by maneuvers.
Okay, that's great. Again, this comment.
Very, very low. Very
1
low.
in 25 angioplasty. He relies on his technique, not on the backup techniques.
I am not in a hurry at all, and I always know that sometimes when you retrieve it all the way back to the bend and come back again, the flow diverter property completely changes.
Yeah, keep playing with it. One can play with it. And I think all kind of flow diverters, the same techniques will hold true.
That's
I mean,
the same. I
to
think
feel,
that
I mean, all
of
these,
them are
okay.
reasonably good. I think
Some
that
of them are
our-
softer. You should be careful with bumping, maybe, or maybe yes, maybe that's what you meant. I mean, in terms
Be
of.
gentle, and
Yeah.
whenever you do these maneuvers, especially bumping, make sure your visibility is good. Collimate the beam so you just see that well, so that don't do
Yeah.
things without seeing. They
That's
tell you
another
disaster.
key point.
So any difference in the maneuver between the nitinol-based FDs and the cobalt chromium based?
No, there is no difference really. Seriously, there's no difference. It's just that nitinol opens, probably opens a little easier, it's a little softer, but the maneuvers are the same.
And I think proximal end differs a bit in this FD.
Little
Some
bit.
FDs will take the proximal bumping more easily, sturdier, and some of them are not. And another key thing which was mentioned here, looking at the images. Now, a lot of you may be working on cardiac system, single plane system, but cardiac system have got single shots. So please use the maximum, zoom it up as much as possible, take those single shots, keep looking at the FD.
It helps a lot. If you make your beam very tight,
Yeah.
we are radiologists, you understand the concept
And-
that the
and-
quality of the beam improves.
Yeah, and plus like he showed a Vaso CT or Dyna CT in the end, even if you don't have it, use different angles. In cavernous, in one plane will look fine, other plane, so use caudal, look for lack of opposition and play around with it. Don't be, okay, it's done, it looks open, it's fine. The more you oppose it well, less complications and more efficacy of FD
The
is
last,
very, very
but
important.
not the least, never be scared to pull out the FD.
Yeah,
Yeah, I mean, you can talk to the company later.
yeah, they will give you
but
another one.
Don't say, I have to put it.
No.
There's no way, I don't have a second one on the shelf. I mean, those can be
Yeah.
very, very disastrous.
Yeah, yeah. If you are really having trouble, is twisted, is not
Yeah.
working out, aborting is better, having a complication is much worse. 10 good cases and one complication takes away all the good, all the reputation achieved of 10, 15 good cases. So again, that is very important. And don't be afraid to contact somebody, you know. So I think this talk was great. We wanted a supplementary talk. There is no need for it at all, because I think Dr. Mathew has covered everything quite well in this presentation.
Can we move to the next one?